Good morning, everyone. I hope you all had a lovely evening yesterday, and thank you so much for joining us this morning for the third plenary. So it is my pleasure to kick us off for the second day of the Priorities 2024 conference. As mentioned, my name is Beverly Essue, and I'm an associate professor of global health in the Institute of Health Policy, Management, and Evaluation at the University of Toronto. Most of my research, teaching, and practice is focused on examining and addressing equity-related challenges within health systems. So it's really a distinct honor and pleasure to join you today as the moderator of this morning's plenary, which is on the topic of ethics at the heart of health priority setting, striking a balance between efficiency and equity. While the topic of this plenary, how to achieve both equity and efficiency as aligned and coordinated goals in health systems, is by no means new, it is timely for it to receive focused attention at this conference on priority setting in 2024. Over the past decade, health systems around the globe have been striving to accelerate momentum to achieve expectations and commitments set by the Sustainable Development Goals, while also taking off course somewhat in necessary pivots and adaptations required to address and control emergent challenges posed by the COVID-19 pandemic, the brewing climate crisis, widespread conflict and forced migration, and other geopolitical pressures. These pressures are also occurring against a backdrop of increasing recognition and intolerance that processes and practices within health systems have for too long fallen short on achieving equity goals, in part because they pay too little attention to the needs and preferences of all of their constituents. In catering to the average experience and outcomes, many communities and subpopulations, especially those impacted by the social determinants of health, have been marginalized and put at increased risk of poorer outcomes within all health systems around the globe. There are now resounding calls to plan for intersectional identities within populations, also not a new concept, but it has not yet been mainstreamed in the dominant approaches used across the collective disciplines reflected at this conference. These same disciplines that are trusted to inform, support, and guide priority setting for health and healthcare. And this is further complicated by the fact that the literature on health system equity, our knowledge trust on what to do with and for whom to address health inequities, remains disproportionately and arguably inappropriately dominated by research led by and from the global north. So we find ourselves at an important juncture, which I would like to invite all of us to view through the lens of opportunity. Health system planning for equity and efficiency calls for new methods, new approaches, new perspectives, new actors, collaborators to overcome this false dichotomy that is often drawn between equity and efficiency, which has positioned them as mutually exclusive and undermining goals when in fact, the interconnectedness of these objectives are critical for driving sustainable and inclusive development, including health system development for universal health coverage. Too often, discussions surrounding equity and efficiency have been framed as opposing forces, perpetuating the notion that pursuing one will necessarily come at the expense of the other. However, this binary perspective fails to capture the nuanced and potentially synergistic relationship between equity and efficiency in policymaking and governance. So in the plenary this morning, we aim to take on this challenge. We are joined by 4 dynamic speakers who will first briefly highlight areas from their respective research and practice that are driving innovations in the development of equity-focused methods and research to push disciplinary boundaries and better integrate equity into health system priority setting and planning. We are going to start off with 3 case studies from India, from Laos, and from Thailand. First, Professor Sitanshu will highlight a case from India, and he's going to discuss how equity considerations have been evolving in the context of HTA in India, and will briefly share lessons from mixed methods research used to elicit and integrate societal preferences for the aversion of health inequalities in southern India. Next, we will hear from Professor Mayxay, who will speak to a contemporary challenge facing hospital governance in Laos. He'll share lessons on recent experiences for autonomizing public hospitals and the implications that this has had for improving health equity in their setting. Dr. Phusit Prakongsai will then speak to recent experiences from right here in Thailand with using distributional cost-effectiveness analysis to support equity-informed priority setting for universal health coverage. And then we're going to shift gears slightly, and we're going to hone in and focus on a particular set of methods that have been used to integrate equity considerations into priority setting via economic evaluation. Professor Ole Norheim will highlight the distributional cost-effectiveness analysis framework as a method that has been developed to embed equity considerations into the technical exercise of assessing value in health system interventions. Finally, all speakers will join me on the stage for what we expect to be a very interactive discussion with all of you. And we welcome commentary and questions. So we encourage you to use the app to start inputting your questions, or invite you to use the old school style of using the microphones on the floor. We'd like to hear your voices directly. So without further delay, please join me in welcoming Professor Sitanshu from the Jawaharlal Institute of Postgraduate Medical Education and Research. Thank you.
Good morning, everyone. Namaskar. I am Sitanshu, and I'm going to talk about some of our experiences on this topic. Before I begin, I must congratulate the team of HITAP and all the members who have joined here. It has been a wonderful session and a wonderful conference as of today, and I'm sure that it is going to be the same in the next 2 days as well. So my disclaimer. I have no conflict of interest to declare. The ideas and opinions that are going to be shared in this presentation are personal. Here is the plan of the presentation. I'm going to talk about 3 things. Let me first give a background that Beverly has already given us, and then try to go to the equity in our HTAIN concept in India. And finally, we'll come back to our a small research or pilot study that we did in India, Puducherry region, and try to see the results, because this is still work in progress. We are still learning out of it. So some of the ideas that we are going to share, and we'll also welcome questions and comments, suggestions from the crowd. So decision makers have a dual objective, as we all know. Yesterday we have discussed this. First, to look at maximize health of the population, and the second is minimize the unfair health distribution in health inequality. So when we're trying to look at these 2 concepts, we always see that the efficiency part takes precedence. So the maximization of health always comes to the first, or to the forefront in decision making. So when we're trying to look at this balance, how do we then position equity in our decision making in priority setting as well? So why should we look at equity as a whole in the whole decision-making process? Because if you look at this prism, when the ray of light goes through it, what happens is basically it goes and diverges into the natural colors. So in efficiency parlance, when you look at to the left-hand side of the screen, you see that the average cost and effects of the outcomes are the first. Decision makers are very happy to talk about that and try to position their interventions based on the priority and the ranking and select the top one. But with the same equal efficiency, people can have different, distributional problems. Like, so the rich can, or the upper socioeconomic status people can have a differential benefit, or someone may be left out. So this is the reason why we should also look into this concept of equity into the decision-making process, and that is why we are here to discuss about the issues pertaining to it. So the second part of my story is about HTAIN in India. HTAIN in India started with the background of the third health policy, national health policy of India was launched in 2017, the first one in 1983, the second one in 2002. But in this national health policy, apart from other important parameters, there are 2 major policy decisions were taken. The first one is to create 150,000, that is 150,000 health and wellness centers trying to look at, target the primary healthcare setup. Now we call it as Arogya Mandir, the Temple of Wellness. And the second one, and then in the Temple of Wellness, there will be 12 expanded range of services for primary care, which is going to be available free of cost to the people at their doorstep. The second part, which is very important for us, is also to look at the Pradhan Mantri Jan Arogya Yojana. It is the insurance scheme, short form as PMJAY, which is the world's largest health assurance project, which started with, looking at providing secondary and tertiary care for the population. And the population that is targeted here is bottom 40% of the population, with hospitalization coverage of about 5 lakhs rupees, which comes to around $6,500 US per family per year. 120 million families were covered in this scheme, which amounts to around 550 million people, because the family size is roughly around 3 to 5. So if you add it comes to around about 500 million individuals which are covered through this. 340 million Ayushman cards were distributed as of today. 65 million beneficiaries have availed service. 30,000 empaneled hospitals, both government and private, they are included. Now there is a health benefit package because people are going to be using these services. In the health benefit package 2.2, there are around 1,900 health benefit packages were identified, and that is the role where HTA plays an important role along with the National Health Authority. Now, the mandate of HTA to support this decision-making, the HTA came into existence with 3 primary mandates. The first one, maximize health. The second one, reducing out-of-pocket expenditure. And third one, to talk about inequality, reduce inequality. So this is there in the mandate, but the focus is still on the first 2 components, and it has been now going to focus on the third one. So this is the ecosystem in which the DHR, the Department of Health Research, works. We have an HTIN board. There are user departments from the state government and from other health departments. They give the questions that they are facing, and that comes to the DHR Secretariat. The DHR Secretariat tries to use a checklist to prioritize those topics, and those topics are allotted to resource centers and the technical hubs. From those resource center and technical hubs, we conduct these economic evaluations, and then finally it is approved by the technical appraisal body, and it goes to the board for implementation. So when we talk about inequality, we looked at some of the reports that were there presented or publicly available. We found that the equity concerns are limited to secondary data analysis or subgroup analysis or literature review. We have not seen reports which talk about advanced methods like DCEA or distributional cost effectiveness analysis. So that led that curiosity, and that why don't we start something about it? And then we went to this particular exercise, conducting this exercise in our institute, where the health inequality aversion survey was carried out. DCEA has got many building blocks. If you are there in the yesterday's organization, then we have discussed all those points. For the not repeating those, let me go straight into the study that was done. The objective of the study was to elicit the level of health inequality aversion in the districts of Puducherry, southern India. It is a city where 1.5 million people live with a high literacy rate, and it's one of the best performing union territories in India. And the second objective was to estimate the health-related social welfare functions. Can we develop Atkinson's and try to get the equity weight so that we can take a decision in a better manner? So to meet these objectives, we did a mixed method design, and the quantitative part looked at how do we do this survey using the paper that was published in 2017 by the York University. Matthew is here, thank you so much for that. And the quantitative part was the survey that we conducted, and also tried to understand whether this questionnaires or this tool is applicable to in our setting. We also tried to look at the qualitative component, how people perceive the survey, what are the issues pertaining to it. So in the methods section, we interviewed around 609 individuals, 70% from the urban, because that is how our population is distributed, and 30% in the rural. We have some modifications to the methods that was proposed in that particular paper. We had a face-to-face interview. There are many studies conducted in different parts of the country where people went for online interviews. We did face-to-face interview, and then the health disparity questionnaire was used for data collection. In the qualitative component, we looked at fairness, inequality, and survey methods, the perception of people. So if we look at the results, if you see that the distribution is usually described like this, where we start with one corner from pro-rich to the other corner of egalitarian, where we, let me put this together. Yeah, so in pro-rich, the population favors the health gain for the rich, and in the egalitarian, they prefer to reduce health inequality so much that they are willing to sacrifice potential health benefits to the worst off. Maximin is the group where prefer to improve the health of the worst off. But if you look at the distribution, we found in our population, majority of them were talking about the egalitarian concept. So if you look at the median distribution, that helps us to calculate the health social welfare index. It comes in the egalitarian section, and it becomes a little difficult for us to calculate the other indicators for that. So we also looked at for gender and area of distribution, male, female, and the rural, urban. We found the similar type of distribution there. Mainly, people are talking about the median rate, the response is in the egalitarian. So the median respondent was egalitarian. 85.2% of the participants were willing to trade off some total health in order to reduce health inequality. We have some concerns about these findings. We are trying to understand it in a better way, why we found this. We'll look at this. So look at the qualitative component. In the qualitative component, we did interview about 15 people where we assessed fairness, inequality, and survey methods. I'm going to talk about the survey methods component alone. Here, the major findings when we did the inductive coding and try to do the thematic analysis, we found that people reported that it is not very easy to understand these questions. The 7 scenarios that we presented to them for decision-making, the policy decision-making, were difficult to comprehend, and the specific examples will add in understanding. It is a very generic example that we give policy A versus policy B. So to summarize, my take-home message will be inequality aversion surveys are in an infancy in our country. It needs to be given importance, and then finally we take it further. The face-to-face interviews reduce the need of video. There is, in the method section, I did not mention about the role of video, but when we did the video component, it tried to confuse the respondents, so hence we did not use the video in our survey. Majority are willing to trade off some total health. The calculation of health-related social welfare index for our population will need some further analysis. We're going to work in this particular direction. So this is the acknowledgement that I would like to end with. This is where the journey of equity started for me. That is in 10th HTA Asia Link conference. There are people who are sitting in this hall who are very kind enough to put together a group. Then in 2011, in the 11th annual HTA Asia conference, we also presented as a workshop, and we also did it yesterday. So thank you so much for all those people who are involved here. Their affiliations are mentioned. I'm running out of time. Thank you so much for your kind attention. Thank you so much, Beverly.
I think it's an excellent opportunity to see the translation from what was proposed as a method in the academic literature and starting to see it in practice. And I think as we all are familiar with, there's nuances to work out in terms of the development of the method as it's applied. So it's important to hear these examples and to see that journey that you've reflected on at the end. All right, I now would like to invite Professor Mayfong to the stage. Thank you. Professor Mayfong is from the Lao-Oxford-Mahosot Hospital-Wellcome Trust Research Unit. Thank you.
Thank you. Good morning. Sawadee krab. So thank you for the kind introduction. Uh, what I would like to share and discuss with you today is about autonomizing public hospital in Laos. Frankly speaking, this is not my field of expertise at all, and it is not what I am doing, but it is something that interests me. So in this conference, I would like to learn to hear from all of you regarding your reflection or thoughts and comment. Just to explain you a bit about the term autonomizing public hospital in my presentation context. At the moment in Laos, the majority of the hospitals are running by the government, and we have some private hospitals as well. So the public hospital is supported by the government, who provide the staff salary, pay for electricity, water supply, procurement of medical supplies, equipment, and etc. And now the government cannot afford anymore about those costs. So they are planning to make the public hospital to become autonomous. We are now implementing the phase 3 health sector reform strategy with the two main objectives in this phase. Number one is to improve the quality of healthcare in the country so that it can be comparable with that of the neighboring countries and other countries in the region. And the second focus is to achieve the goal of universal health coverage by strengthening primary healthcare. And in the phase 4, which is from 2026 to 2030, the Ministry of Health would like to ensure that we have comprehensive development in health sector that include also hospital autonomy, and to encourage the private sector to contribute to the public health service in the country as well. However, autonomizing public hospital remain controversial. For example, some evidence suggested that having public hospital to be autonomous can lead to higher out-of-pocket on hospital care of the patient. It can also increase the expense of the patient per treatment episode, or sometimes it can also lead to more intensive style of care with more laboratory tests and imaging per case, for example. Some other studies suggested that having public hospital to be autonomous that can lead to decreased equity in accessing to healthcare. It can lead to the compromised efficiency and poorer quality of health. And also it can undermine the social health insurance because the healthcare cost will be increased as well. In contrast, some other evidence suggested that having autonomous hospital may lead to greater efficiency, better quality of service, and this can increase the choice for the patient as well. Then, why is autonomizing public hospital, is it good or not? So, well, if we have a very effective governance and structure and oversight mechanism, the hospital can be flexible in terms of management and administration, and this can lead to also the tailored service, better service, and having more innovation, and all of this can lead to the better efficiency of the health service or the hospital management as well. However, there are some challenges. For example, there is a risk of inequity in accessing to the healthcare of the people. There can be some fragmentation. Different hospitals may practice differently in terms of management and administration. And also, some hospitals may not comply with the regulations set by Ministry of Health or the government. And there can be also the issue of accountability and that can lead to financial instability as well. And why Lao government is doing this? This is the main reason, because the government is now facing with economic downturn and also financial difficulties. The inflation rate is now increasing day by day. And this is the data, the analysis from the World Bank suggesting that there is increasing the percentage of inequality trend in the country year by year. And of course, the people are now suffering from that impact as well. Actually, before the introduction of the hospital autonomy in Laos, there is an assessment by a group of experts from China to see whether this is okay or not. And these are some conclusions from the assessment. Number one, the group of experts suggested that the hospital autonomy in Laos could be an alternative option, but this should be carefully designed and implemented. And second one, they recommended that we do a pilot in selected public hospitals first, and then conduct careful evaluation to see whether the granted autonomy can lead to intended social goal of equity, quality, and efficiency or not. And lastly, they recommended that we should have a managed hospital autonomy rather than a total free autonomy. Later on, the pilot was conducted in 3 central hospitals in Laos. And these 3 central hospitals are the biggest one. It's a primary to tertiary hospital, referral hospital, serve the population of around 1 million in Vientiane capital. So started from 2021. So what have been done so far? So in order to make the hospital more efficient, to make the patient more happier in getting the service, so many things have been done in the past 3 years. For example, frameworks, decree agreements, and etc. have been developed and issued or endorsed. Many committees, subcommittee, or ad hoc boards have been established and been functioning. Lots of meetings, seminar, training were organized for the hospital manager and doctor and nurses as well. And of course, there is improvement in facilities and also quality of the service as well. As you can see, the picture on the right-hand side here is about the implementation of the slogan of the Ministry of Health in order to satisfy patients regarding the service. So we call the slogan is 5 good, 1 satisfaction. The first good is a good warm welcome. The second one is good convenience. The third one is good cleanliness. The fourth one is good diagnosis. And the last one is good treatment. And 1 satisfaction is the patient satisfaction. So what are happening now? Well, in terms of efficiency, we can see a bit improvement in terms of the service. For example, it is faster, more convenient, but it is too early to see whether the healthcare is efficient at the moment. But we are now seeing some sign of equity issue. For example, of course, the hospital try to earn more money, and of course, the treatment cost is increased. Out of pocket of the patient also increased. There are more some lab tests requested by the doctor, for example. And of course, the number of patients visit to OPD, the number of bed occupancy is also reduced as well. So that is all for my presentation. Thank you very much.
Thank you very much for that. So, one of the takeaways I've taken from that is that, the importance of sort of planning explicitly for equity, implicitly expecting it to come about doesn't necessarily come through. So I know these are early findings that'll be important for us to sort of monitor and see, and it seems like evaluation and monitoring is embedded in that program. All right, I would now like to invite Dr. Phusit to the floor. Thank you.
Good morning, and thank you very much for the introduction. First of all, I would like to thank HITAP, the Ministry of Public Health Thailand, and organizing committee for inviting me to share my views and experience in reducing health inequity and DCA through the case study of universal health coverage policy in Thailand. Just in my presentation, I would like to draw the Thai experience in the equity impact from the introducing of the universal health coverage policy in Thailand in 2002. Just would like to share with you about the long march to achieve universal health coverage in Thailand. Prior to 2002, the proportion of the uninsured in Thailand was greater than 29% of the population. And after the Big Bang approach in 2002, we achieved the universal coverage in 2002, and almost 100% of the Thai population were covered by at least one public health policy scheme, insurance scheme in Thailand. And the objective of the universal health coverage policy were to provide equitable access to essential healthcare services and provide financial risk protection from the expensive medical care costs. And after achieving the universal coverage in 2002, there were 3 public health insurance schemes covering the entire population of Thai citizens in Thailand. The first one is the Civil Servant Medical Benefit Scheme, or CSMBS. This is the tax finance scheme for government employees and dependents, around 5 million of the population. And the second one is the social insurance, which is the payroll tax finance scheme for private sector employees, around 11 million of the population. And the last one is this is the universal health coverage scheme, which is the tax finance scheme for the remaining population, informal sector population, who are neither CSMBS nor social insurance members, around 49 million of the population. And we also employ the health technology assessment, including the cost effectiveness analysis and budget impact analysis for making decision on the including of any new health technologies and health interventions into the UHC benefit package. And we also conduct the health equity assessment and equity impact of the policy prior to and after implementation of the universal coverage. And this is perhaps the historical development of the healthcare intervention and medical treatment included into the Thailand Health Universal Health Coverage Benefit Package. So you can see that at the beginning or the commencement of the Universal Health Coverage policy and benefit package, we already include perhaps a very comprehensive benefit package covering outpatient service, inpatients, and rehabilitation, capital replacement, Thai traditional medicine, and no fault liability for the health benefit package of universal coverage policy. But at the beginning, we start to exclude some expensive health services, such as antiretroviral for HIV patients, because it was very expensive at that time in 2002. And we also exclude some interventions such as renal replacement therapy for chronic kidney disease, because it's also very expensive at the time as well. But after we implement the policy on universal coverage, perhaps 3 or 4 years, there's a new evidence on the cost-effectiveness analysis on the ARV drugs. So the government at that time in 2006, they changed their decision to include the antiretroviral drugs for the HIV/AIDS patients in 2006. And in 2009, the government started to include renal replacement therapy for chronic kidney disease. And this is perhaps the development of the universal health coverage benefit package in Thailand right now. And in 2020, National Health Security Board has approved the inclusion of some medical treatments and lab investigations for some rare disease into the UHC health benefit package as well. So this is the impact of the universal health coverage policy in Thailand, that we use the UHC cube from the WHO to explain what is the impact of the universal health coverage policy, including this UHC cube. And you can see that on the x-axis of the population coverage, we can cover around almost 100% of the population in the universal coverage. And on the y-axis, we employ the free at point of services with very low minimum out-of-pocket payments. This can lead to the reduction in the incidence of the catastrophic health expenditure and health improvement from the medical care costs. And on the z-axis, we provide an extensive, comprehensive benefit package and a small exclusion list. Almost all high-cost interventions will be covered by the universal coverage scheme. So this can facilitate access to more equitable access to healthcare services, especially on the essential and expensive medical services. And this is the benefit of the universal coverage policy in Thailand, that we conduct the equity assessment. We can see that there's an increase in health utilization and very low unmet need of the population in Thailand since the beginning of after we implement the policy on universal coverage in 2002. And UHC can reduce the poverty in addition to the improving health and better access to health. And Thai experience on universal coverage can protect the number of households from being impoverished from medical care costs. And another side of the health benefit package of the universal coverage is that we can provide equitable access to antiretroviral and expensive health services, resulting into the achieving of the ending mother-to-child transmission of the HIV/AIDS in Thailand. And Thailand is the second country of the world in ending mother-to-child transmission of HIV/AIDS in this country. And this is perhaps the equity impact that we conduct the equity impact assessment on the universal coverage policy in Thailand. And we found that if we try to perhaps use the design of the universal coverage to use the primary care as the main contractor of the universal coverage. So you can see that in this graph that we analysis, we found that ambulatory care service at the health center and community hospital, this is the healthcare services that promote the use of the poorer population of the society. And this is the key lessons from the improving health equity and support from the DCA for implementation of universal coverage policy in Thailand. We found that evidence from the economic evaluation and ICR thresholds are not the only criteria for including new health interventions into the universal coverage benefit package. Sometimes it is the political economy reason, and prevention of the health impoverishment and catastrophic health expenditure is, would like to key driver of the policy making decision in Thailand as well. And other criteria on the ethical dimensions, such as benefiting the poorer populations, and for some diseases, highly concentrated among poor populations, will be used for priority setting of health interventions and scoring for health priorities. And inclusion of primary care and close to client health services, cost-effectiveness interventions, and new health technologies mainly benefit by lower socioeconomic groups and marginalized populations will improve the level of the DCE approach. So when we reviewed the literature, we found that this is the equity, efficiency, impact plan proposed by the Center of Health Economics. And we think that this is the way that we conclude from our implementation of the universal coverage, that we can have the win-win situation between the cost-effectiveness analysis and perhaps the efficiency improvement and equity impact as well. Thank you very much for this.
Thank you very much, Dr. Phusit. So that's an excellent segue to now invite Professor Norheim up to the stage, who's going to delve a little deeper into the distributional cost effectiveness analysis and some of the methods development for embedding equity in economic evaluation. Thank you.
Thank you. And I'd like first to thank the organizers for putting equity and fairness at the core of this conference. And I actually think this conference is so well organized that HITAP should organize it every time. That's my proposal. So equity and fairness is at the core of ethics and of social justice. The theories of distributive justice developed by John Rawls, Amartya Sen, and others, they discuss always this trade-off between equity and efficiency. And Norman Daniels and other ethicists have also discussed it in the case of healthcare distribution. And as Beverly said, maximizing health and reducing inequities often go hand in hand. So it's not always a conflict between equity and efficiency. But when there is a conflict, we might have a trade-off. And that's what I want to talk about. So there's been research innovation in this field. And here I have to declare my conflict of interest. I'm a co-editor of this volume on DCA together with Richard Cooksons and other health economists at York. My contribution was more from the ethical side. But the idea is very simple, and it was first developed by the Indian philosopher Amartya Sen, that you can look at social welfare by looking at average benefits, what we do when we calculate cost effectiveness, but also measure equity impact. And then when you combine it, average health multiplied with 1 minus the inequality measure, if there's a lot of inequality, social welfare will go down. So that's the core of this trade-off. And DCA is a tool to measure and model equity impact and also analyze the trade-offs. And if we have information about the inequality aversion, how much you hate inequity, if you have a strong aversion to inequity, you will put a lot of weight on improvements for the worst off. That's what you talked about, and trying to measure that in populations. So let me give you an example, a very concrete example of the application of DCA. You can use it for HTA or for benefit package design. And this is an example from Ethiopia. So the Ethiopian team, they did a cost effectiveness ranking of more than 1,000 interventions. And this is one result that was published. The Ethiopian team did it together with the WHO, with Karin Stenberg, who is here, and others. And this is just one example from the nutritional interventions. And Ethiopia is a large country with more than 100 million people. It's a low-income country. GDP per capita is around $1,000 per capita. And if we believe the cost-effectiveness threshold proposed by the York group, Carl Claxton and his team, they suggest that roughly the cost-effectiveness threshold should be around 50% of GDP per capita. So here is an intervention that costs 693 per DALI averted or quality-adjusted life year gained, daily iron and folic acid supplementation for pregnant women. There are about 3 million pregnant women every year in Ethiopia. What we see here that according to a cost-effectiveness threshold of $500, it would not be considered cost-effective. So it should not be included in the benefit package. But what if we believe, and we know there is a social gradient, women with lower socioeconomic status have higher prevalence, higher risk of anemia. So what if we care about equity? Should it be included in the package? That would be the question. And then we have this very nice tool. It's a shiny app tool developed by Richard Cookson and James Love Coe at York. You'll find the address here. I'll happy to share the slides later. In this tool, you can model equity impact and analyze trade-offs. So you can put in either data, or you can make some assumptions and play around with the numbers and see what would the impact be if you put in different input parameters. You can also include the cost-effectiveness threshold, and you can put in your inequality aversion parameter. And in the case of iron supplementation, there will be higher benefits for the worst off groups. And in addition, you can assign more weight to benefits to the worse off. And that might change the cost-effectiveness calculation. So I did this for this example. And if I made it simple. So the cost-effectiveness of this intervention is $600 per DALI averted. The threshold is 500. So then it wouldn't be cost-effective according to standard cost-effectiveness analysis. So this is summarized here. Cost-effectiveness 600, threshold 500. And there's an error there. There should be 35,000 qualis. That will be, it's easier to explain it here. It's not cost-effective. And the idea of marginal productivity is that if you introduce something that is not cost-effective, you will displace other benefits. So it's actually a loss of qualis, 35,000 qualis. So in this case, you have to choose. Do you want to achieve less qualis, less health, or not? If you care about equity, you need to put weights on the benefits, the qualis for the worse off, then this calculus might change. And from the tool, we can now, with the inequality aversion parameter, I've set it at 4 in this example, the decision maker can decide, or we can do population surveys. And when we value qualis more for the worse off, you will count it as more benefits. So then the cost-effectiveness ratio change. So you see here, equity-weighted cost-effectiveness ratio would be 484 in this case. So then it would be pass the cost-effectiveness threshold test. And this can be illustrated in the equity efficiency plane. So you see here that if we did standard cost-effectiveness analysis, on the y-axis, it would be minus 35,000 qualis. So with the cost-effectiveness threshold, it would not be cost-effective. But if we weigh, it's a red dot to the right, we have more equity-weighted qualis, more than 40,000. So it's a positive gain. And it all depends on how much you weigh qualis gained for the worse off, and that's informed by the inequality aversion parameter. So qualis gained for the poorest are valued more. That's the core of this method. And the conclusion is that this intervention would be cost-effective if we are willing to attach equity weights. So in summary, this have implications for HTA and also for benefit package design. So you can look at, you don't need to look at interventions that are very cost-effective because they would be clearly included in the benefit package. You don't need to look at interventions that are not cost-effective at all, but around the cost-effectiveness threshold. You can do this modeling exercise, and if you think it's plausible that it maybe should be included, you can do a deep dive and do a full distributional cost-effectiveness analysis. So interventions with high equity impact will be ranked higher when you use this method. And of course, then other interventions with no equity impact or little equity impact will be ranked lower. So that is the way it can be applied. And there's a lot of people in this conference who have done research. There's a group now working on this, measuring aversion to inequality in Japan, in the US, in Thailand, in Norway, and a lot of countries. So this is a growing research agenda. And I'll invite everyone who is interested to dig deeper into this. So my final conclusion is that DCA makes it possible to quantify this concern about equity and fair distribution. And then it will have an impact. Thank you.
Okay, so thank you very much for that. I'm now going to invite all of the speakers to join me on the stage. I'm going to exert moderator privileges here. One of the questions, maybe one of the critiques that are often raised with trying to incorporate equity formally within priority setting is, what about the data? So in settings where we're trying to collect data on burden of disease, et cetera, now making an ask for distributional data is one more demand. I wonder if you all can speak to experiences. I know you reflected on it with the use of the survey, so maybe we'll start off with you on how in your respective work you're addressing this issue around ensuring there are sufficient data to support equity-informed analysis.
Thank you so much for that question. And it is actually a very, very relevant question. What happens is, when we try to add layers to analysis, we need to have information, and that information comes from some source. Whether that source is reliable, whether you can believe on that is also another question. So in our case, when we started, that's why we started with a low-hanging fruit. The social inequality aversion survey probably was under our control, and then we started with that. But the baseline distribution of the variables that should be that is the first step in doing DCEA. There are other ways of looking at it. We have some nationally representative surveys which are available. The data are available, like NFHS, and but this is a little dated. So the recent data is a problem. So that's a challenge. So we need to find some solution for it. But the process has to start somewhere. So I see that this is an opportunity to try to do in certain areas, and slowly the data probably we can generate in our setup, and slowly it can be from that. So I think this is an opportunity for working in this area, and probably the secondary source data, we can find out the source and try to do it from there. I'll stop here. Thank you.
Okay, thank you.
Yeah, so DCAs are data hungry, so you need a lot of more data. But it's not impossible. A lot of you do HTAs, so you will have a basic cost-effectiveness analysis done. And then you can model the effect and the impact on equity. You often have some idea of the social gradient, of the risk, of the coverage and the uptake. And you have demographic health surveys, other types of services. So if you have data, you can use those. If not, you can do modeling and make some assumptions as an approximation, as a start. And when you have found interesting cases, you can dig deeper and collect your data. Then you need data on inequality aversion. There's ongoing research on this, but you can also do equity sensitivity analysis. You can use a low aversion to inequality parameter or a very high and see if it makes a difference. So I will encourage you to dig deeper into this. It's not impossible.
Yeah, thank you. For Laos, we would like to confess that we have very little data in any areas. Basically, we just rely on the National Health Survey. For example, the LSIS, the Lao Social Indicator Survey, for example. And regarding the HTA, we are now in the early stage. We just established this kind of work called Unit for Health and Evidence Policy in the country with the support from the HITAP. And the first, for example, I give you one example. The first piece of work that we have just done and published is about the cost effectiveness analysis of the introduction of typhoid vaccine into the EPI program. And by doing that, our team were facing with the lack of data. And then in many occasions, they have to just do the assumption and also extrapolate the data from only one or two studies only, for example. So we can say that in the low income country like Laos, we lack a lot of data to refer to, and also we lack of the staff who are champion in HTA cost effectiveness analysis, for example. But anyway, we are now supported by our colleagues like Moru team in Bangkok, HITAP, and also some team from University of Oxford, for example. And hopefully this will growing up and we will do that nicely in the future. Thank you.
Thank you very much. From my experience in Thailand, we are quite lucky that because in Thailand we invest a lot on the perhaps the database in Thailand, especially on the nationally representative household survey in Thailand, that we already have health and welfare survey conducted by the National Statistical Office that we can reflect about perhaps the health service utilization at any level of the healthcare services facilities in Thailand. And we also have a National Health Exam Survey which conduct every 5 years for the National Exam Survey in our countries. This is financed by the Health System Research Institute, HSRI, and Thai Health Promotion Foundation as well. So this is perhaps our fortunate that we have a database on the nationally representative household. But the question, perhaps our problem is that we try to coordinate with the National Statistical Office to perhaps include some questions and perhaps some of the socioeconomic parameters that we can classify people into the different socioeconomic groups. That are our attempt and our efforts in the database system in Thailand right now. Thank you.
Thank you for that. So I heard, commitments to start somewhere, collect, implement new surveys, and there are examples of tools that are in place to be able to get started, delve deeper in the data that are available, extrapolation and looking for similar experiences and lessons and drawing on some of that data. And then the Thai experience, which is a real focused commitment to investment in data infrastructure to support an understanding of equity. There's a couple questions that have been raised that I think at the heart of them are asking, how do we reconcile differences in understanding and definition of equity within your own context, but also across contexts? We often see the distribution as an income distribution. I think you spoke to looking across gender. How do we decide what definition of equity we use if we want to take this work on? Sorry, I'm looking at you. Let's go first.
Yeah, okay. So equity is a complex question. It has many dimensions: gender, urban, rural, socioeconomic, marginalized groups. Think about everyone who's in jail. A lot of these marginalized groups. So we have to discuss this, decide that, and depending on what kind of data you decide on to collect, then you can use your analysis. But that's a political decision about who do we care of. So I think a good label is the worse off. So people are worse off in many different dimensions. Even severity of disease can be incorporated this way. So there are many dimensions, and ideally you would like to capture all these dimensions, but you have to make choices, and WHO has given some advice on some of the key parameters that are relevant for equity.
From our experience, we also have problems in terms of the perspective on equity as well, health equity as well, because as you know that we have policymakers who believe in the libertarianism and also egalitarianism as shown by our Indian college. So we also always have a debate between the policymakers, but I think that when we try to assess the impact of the policies on the equity perspective in different ways, so people can understand more and more about the equity. And I think that it would be good that we can allow to people to believe in equity perspective in different ways. Yeah, thank you.
Yeah, I would like to say this. In the setting of low-income country, as you know that in the poor or least developed low-income country, the majority of the people are poor, of course, less educated, and there are a lot of underserved or marginalized population. And these people, when we interview them, ask them about what is the meaning of equity, they may not understand at all. For example, in equity of health service, for example, they may not understand that. Even now, we come to the upper level, that is a policymaker, the healthcare provider, and then they may not understand as well. So the term equity in health access or healthcare, I think it may be different between the setting, for example, between the high-income country and low-income country. Even in the same country, it may vary or different between the urban area and the rural area as well. So it's quite difficult to define it exactly and apply it into a particular situation. And that's why maybe this is my idea, whether we can have a kind of minimum standard or guidelines for having the word or the term equity in health care, for example. That would be good, I think. Thank you.
So I think that's a good segue to one of the questions here that asks, we primarily discuss equity at the national level and perhaps even at the subnational level. What tools and frameworks exist to address equity at a global scale? And they use the example of the failures of initiatives like COVAX highlights our struggles in achieving global equality, not to mention in the realm of AI and other examples. So we're talking here about planning for national health systems and within a subnational context. Can you speak to examples of work to actually roll this up and think about the achievement of equity at a global level?
Okay, let me try. I think the COVID pandemic revealed huge global inequities. We don't need any methods, no sophisticated methods to realize that there's huge inequities in access to vaccines, in survival, and so on. But of course, for the big organizations and the Global Fund, Gavi and others, they also take these issues into consideration, and they might be interested in using DCA. For example, malaria vaccine, should it be introduced or not? You can look at equity impact, both at the national, subnational level, but maybe also at the global level.
During the COVID-19 pandemic, we have ever analyzed inequity about at the global level as well, in terms of the access to vaccine, COVID-19 vaccine. At that time, we found that some countries that is high-income countries, they can produce and perhaps they can purchase COVID-19 vaccine. And people in this country, those countries, they can vaccinate perhaps 4 times and 5 times of the vaccination. But in some countries, it's just 0 or perhaps less than 1 times of the vaccination. So I agree with Professor Ole that perhaps there's no need for any sophisticated analysis of the inequity, global inequity in this case of the COVID-19. Thank you.
If I can add another dimension to the discussion. So during our qualitative component, we spoke to some of the policymakers and we asked, what is equity for you? So they said that we take decisions always considering certain parameters in our mind, looking at who will be benefited, whether the vulnerables are included in it or not, who is going to get the most out of it. We may not have a specific criteria or weight available in our mind, but when we take decision, it is usually trying to look at that population first, then we take it further. So as an academician, from academic point of view, we want to quantify everything. But there are decision-making done in a very complex environment where we have a lot of competing priorities. And in that case, will it be always possible to come up with equity, weights, and other things? That's a debate that is still going on in the mind. When we look at India as a country, it's a big place where you have so many states which are represented as a country at one point of time. The states are also at different state of transition. So when they're talking about fund allocation to various states, they say that if someone is not doing so well or someone is doing well, so is there a differential distribution of the funds that are allocated? Can that be considered as a part of equity? So these are various dimensions to it. So it's very difficult to define and try to get a number, equity, weight. It will be different for a particular condition, for different situation. Context is very, very important in that case. So. Very complex construct to understand, I guess.
So are we potentially overcomplicating it by trying to look across the distribution? And so maybe I'm extending this question that's posted here a little further than the way it's articulated. Would an explicit cost effectiveness threshold improve equity or reduce it?
So maybe we're complicating a bit. I think there are cases where there is a real trade-off in terms of new technologies and so on. But I think we should also think of equity as important in implementation. Securing equal access to cost-effective services will also improve health a lot. And also we should think about the social determinants of health. It's not only the healthcare system that contributes to good health outcomes. It's also better education, more fair distribution of income, tax reforms, and so on. So think about equity in all aspects of health systems, in access to care, in health financing, and in implementation. And then there is a small piece also for priority setting, but maybe actually not the most important.
Yeah.
From Thai experience, we found that perhaps healthcare services is not distributed equally among the different regions. For example, like specialized care for perhaps for rare disease, sometimes it's just only available in the university hospital, or perhaps tertiary care or specialized care hospital which is located in big city and in Bangkok only. So our experience showed that if we finance perhaps healthcare services that are available in the big city, so sometimes it cannot improve the access to healthcare services, especially for those who live in the rural and remote areas of the country as well.
I'm mindful of time, and so I'm going to squeeze one more question, and then I'm going to give you each an opportunity to leave us with your take-home message. I think over several sessions yesterday, we heard about the complexity that many of us still face in communicating cost-effectiveness analysis results to decision makers. Can you reflect on your experiences? I know that you're at different stages in terms of the work and practice, but reflect on your experiences in communicating the equity-focused results to decision makers and the ways in which that information is being used within your particular context.
This is another difficult area. We have not reached there in our experience as of now, but when we go and try to talk about ICER values and try to also make them explain, though in 5 years ago, it was very difficult. Now people have started to understand and try to recognize that this is the way to move forward. But I think the equity efficiency trade-off is also in that direction. So it will take time. It will try to get into the system. The system will mature enough to understand that efficiency and equity are not, they are not competing with each other. So probably it will take some time. It's a very difficult question because the policymakers have a lifetime, time span for their job. 3 years, 2 years, after that there is a change. So every time we have to keep doing this because otherwise it becomes very challenging. So I don't have a direct answer for that question, but trying to learn from others, how do we communicate? Should we do it in a way that the people are going to understand about it? So work in progress.
I think we can be much better in communicating these messages. But many of you advise policymakers. HITAP does a fantastic job in that sense, and our work can often influence the technical people within ministries of health and so on. And if they understand it, they can also help communicate that to decision makers. But basically, it's very easy. Everyone agrees upon reflection that the aim of the health system is to improve health to everyone. That's cost effectiveness. And to reduce unfair inequalities. That's equity.
Yes, for Lao, it's a bit, it's not so difficult because Lao is a small country. The researcher and the policymaker are very close to each other. And also we have a team, what we call a technical working group. Once we get the data information, and then we work with this group and then inform the policy maker. But the issue is that when we pass the message to the policy maker, whether they apply or use those information is another thing. So, and another issue is that we have very little information so far. But however, in the future, I think we will be able to improve that. Thank you.
From our experience, we think that policy makers and politicians, they always need political support from the public. So even though they are the military government, they also need political support from the public as well. So I think that if we try to raise this agenda on the health equity and perhaps equity, perhaps social equity as the national agenda, and this is the public interest. So I think that policy makers and politicians, they will try to achieve this one as well.
Okay, 10 seconds. What is the take-home message that each of you would like to leave with us? Leave us with.
Let's work in this area.
We talk a lot about equity, so my advice to you, many of you young people here, if you want to make a difference, move into quantitative equity analysis.
It's a good challenge.
Yeah, equity is a moral imperative that we have to have it in all aspects of healthcare. Thank you.
For me, I learned a lot from these sessions, and I think that Thailand is very look forward to develop the DCA in Thailand as well after the implementation of the CA only in Thailand for 20 years. Thank you.
Okay, please everyone join me in thanking this panel. And I hope you enjoy the rest of the conference.